spectral Doppler. In a normal and unaffected vessel, the flow within the carotid artery is known as laminar. This is a even parabolic flow, you can see the diagram here, with a relatively narrow range of velocities. And this narrow frequency spectrum is illustrated in the Doppler waveform as a narrow envelope of velocities that enclose what's sometimes called the acoustic window or a spectral window here, an area of relatively little blood flow here in the lower frequency ranges. So it's an envelope of higher frequencies. If, however, you don't see parabolic or laminar flow, you're in a condition known as spectral broadening. This indicates disturbed flow with a larger range of velocities, and again, a filling in of this spectral or acoustic window, because now we have representative blood cells moving at different velocities from baseline all the way to the peak envelope of velocities. Graphically, it's illustrated as a filling in of the spectral waveform here, and also as multiple color flurries on color Doppler imaging. If you do see spectral broadening, the most common cause would be focal atherosclerosis, but there are other things that can give you the same result, namely the disturbed flow that results from an arteriovenous fistula, disturbed flow at an endarterectomy site, the presence of tortuous vessels, and also spectral broadening is common and normally seen in small vessels. Here's an example of an arteriovenous fistula and the spectral broadening at the sampling of the fistula, where you can see this multiple levels of velocity being represented here on the spectral waveform. Velocities and the waveform character can change radically at the endarterectomy site. Oftentimes this has to do with decreased vascular compliance, but the presence of both elevated velocities and high peak systolic velocities and a spectral broadening phenomenon is common at the site of prior surgery. Tortuous vessels are notorious for causing spectral broadening. Oftentimes, particularly in older patients, you'll see vessels that make abrupt turns. And as you can see on this color image, at the abrupt turns, the flow dynamics are changing rapidly. Here's an example of sampling at the prior to a turn and then after the turn, and you can see that the acoustic or spectral window is filled in after the turn because we have a broadening of the velocity spectrum, or this spectral broadening that I'm describing. Not all spectral broadening is easy to identify. There are pitfalls in the identification of spectral broadening. Specifically, if the gain setting of the Doppler is not set correctly, you can fill in that acoustic or spectral window artifactually. Secondly, if you don't center your sampling gate within the lumen of the vessel, but rather have it eccentric in the lumen, say close to the wall, you can get spectral broadening on the basis of detected wall motion of the vessel. And finally, this can be normal when the vessel abruptly changes caliber, as it does as it enters the carotid bulb. Here's an example of wall motion. You can see that my range gate is opened up widely to encompass both the center stream and the periphery of the vessel, as well as the wall itself, and you can see a lot of spectral broadening here. If you sample outside the center stream, here's center stream sampling, you do have an acoustic or spectral window. If you sample closer to the wall, you'll get the spectral broadening phenomenon. Now we'll talk a little bit about spectral Doppler criteria in the diagnosis of carotid stenosis. There are different parameters that are used, the most common being peak systolic velocity and diastolic velocity, the ICA-CCA ratio both in the peak systole and in diastole, and then finally the presence or absence of spectral broadening. There is a useful reference that where this criteria is tabulated. I refer you to two publications of this article, both in Radiology and in Ultrasound Quarterly. It is a consensus conference that was produced by the Society of Radiologists in Ultrasound. The criteria that was agreed upon at that consensus conference is like this. A diameter stenosis in the ICA of less than 50%, which is to say a non-significant stenosis, is identified when the velocity, the peak systolic velocity, is less than 125 centimeters per second, the end diastolic velocity is less than 40 centimeters per second, and the ICA-CCA ratio at peak systole is less than 2. For diameter stenosis in the 50 to 69% range, which is a borderline range that exists between non-significant stenosis and stenosis that is non-surgical, is identified when a peak systolic velocity in the 125 to 230 centimeters per second range and end diastolic velocity in the 40 to 100 centimeters per second range, and an ICA-CCA peak systolic ratio between 2 and 4. Then, diameter stenosis that would be considered in the surgical range or critical stenosis, that is greater than 70%, is identified by peak systolic velocities exceeding 230 centimeters per second and end diastolic velocity exceeding 100 centimeters per second, an ICA-CCA peak systolic ratio that exceeds 4. It is interesting to note that though you may not have the criteria immediately in front of you, but you can make a general estimate of degree of stenosis, remembering that the peak systolic velocity less than 125 is insignificant, but if you double that factor to, let's say, around 250, 230, then you're in the area of critical stenosis. Similarly, you don't get into the area of significant stenosis until about 40 centimeters per second, and if you double that, that's about 80 or 100 centimeters per second, and you're in the range of critical stenosis. And similarly, the ICA-CCA ratio starts to become significant at 2 and becomes critically significant at 4. So if you remember 125, 40, and 2, you can remember really the essence of this table. Now remember, though, that you have to look at everything on the image. It's not enough simply to look at numbers. It's very important to look both at the color and the grayscale, because there will be a high-grade stenosis above which the flow is limited and the velocity will decrease. And here this chart shows it. As the diameter stenosis gets more severe, velocity increases because of that jet effect at the stenosis, but then will drop off precipitously when that stenosis starts to become occlusive. So don't simply look at the peak systolic velocity and make your determination from that alone. That would be a mistake.